All right, today we're at our Palmetto Bone and Joint Newberry office location, and so today we're going to be starting off with some injections, typically hip injections to help patients with arthritis deal with their pain, and then also we're going to be then seeing patients in the office, so evaluating new patients for new problems, as well as existing patients following up from surgery, as well as potentially scheduling patients for surgery who are ready to have that. So we got a busy day. I think it's at least 60 something patients on the schedule for today. So let's get to it. I'll introduce you. This is Vicki. Vicki's our office manager, so she's crucial to the running of this operation. Isn't that right? All right, so this is our fluoroscopy room. So this is where we do live x-ray in order to do guided injections. So that just helps make the injections more precise so that we can make sure that the patients get the best benefit from the injection. Hey, how you doing?
I'm doing too.
Yeah.
I told her whatever was in that last shot was wonderful.
Did great?
It did great.
Wonderful. Well,
in fact, I canceled the surgery.
Okay.
Let me tell you why.
Okay.
I've got to have foot surgery.
Okay.
First.
Sure.
And I thought,
get
a new hip if I can't walk.
Right. Get that taken care of. That's probably a best decision for sure. So we can do another injection, to try to keep it under control until you get ready for it.
Yeah.
So.
And if you get one in your back,
Mm-hmm.
in the middle, does that take care of the whole lower?
It can sometimes.
Okay.
Yeah. So we could always try that.
Can we do that?
Yeah. Have you had a recent MRI? Yeah. So we'd have to get that first.
Okay.
Yeah. So. Just have them make an appointment for a few weeks to come back. We can kind of take some x-rays on it, send you to get the MRI, and then we can get you an injection for that. Sound good? All right, so we're gonna get you lay on your back and head will be down on the pillow here. All right, she's gonna come in with that x-ray and then we're gonna take a picture. Thank you. X-ray. All right, it's gonna be a stick here, okay? Here we go. X-ray. All right, it's gonna be live for me. Perfect. All right, we're gonna put the injection in and then we'll be done. Doing okay? Mm-hmm. Great. Okay, we're all done.
All right.
I'm gonna get you a Band-Aid on there, okay?
Okay.
Now I want you to take it easy today. It takes a couple days to kick in, so hopefully by Wednesday you'll notice improvement in that. Sound good? And that's it. All right.
See you next time.
Sounds good. And then if you give that to them up front, they'll get you checked out. And like I said, just have them make you an appointment for a few weeks and we can look at the back and that.
Okay, all right.
Take care, okay? All right, so we just did a hip injection. A patient unfortunately has hip arthritis, and so she's trying to delay surgery in order to get her foot surgery done. So we did a hip injection just to try to calm that pain down to get her some relief until she can get her hip replaced. Hey, good morning.
Good morning.
How you? I'm doing good. You don't have to. All right, we're doing that left hip today, correct? I like your patriotic shirt. You're ready for the 4th of July, aren't you?
Yeah.
Yeah, hopefully it'll hold over till then for sure. This will be the last one we can get before surgery, but hopefully it'll hold off, last that long.
Can you talk this out?
Yep, so we're just drawing up our medications. So this is lidocaine, which is a numbing medicine, and then we're gonna draw up a little bit of depomedrol, which is our steroid. So this is what helps decrease the pain and inflammation in the hip. And then our last one, we'll get a little contrast. This is just to help confirm that we're in the hip joint once we place the needle. Okay. Yeah, that poor hip looks like it hurts. Okay, I'm sure. We're gonna get it better for you though.
Okay.
All right, it's gonna be a stick here, okay? Here we go. X-ray. Okay, go live for me. Perfect. All right, we're just gonna put the medicine in and then we'll be done, okay? Okay, we are all done. I know. Okay. That's it. I'm gonna get you a Band-Aid on there. And then I want you to take it easy today for me, okay? And then shot hopefully by Wednesday will kick in and then be feeling better with it. Sound good? All right, and then just hand that to them on the way out.
Thank you.
And then take it easy today.
Okay, thank you.
All right, I hope it helps and we'll see you in September.
Okay, thank you.
You're welcome. Yep.
Thank you.
All right, so just to recap there, this patient has pretty severe arthritis in her hip. She's already scheduled for surgery, but it's still a couple months away. So we're trying to do an injection just to help make her more comfortable because she is hurting a good bit to help get her to time for surgery. So hopefully that'll help her a lot and she'll be feeling, reasonable until we can get her surgery done in a couple months. All right, so this patient's coming in for right hip pain. So this is an MRI scan the patient's had done looking at the right hip. And you can see on the right side here, all of this white, that's edema within the bone. You don't see that on the other side. And then he's got this area here where the bone is basically died. So this is what is called avascular necrosis. So it's like a stroke to the ball or the bone. And so all of this bone is dying. And so it would take a hip replacement in order to fix that. So that can be fairly painful. He's got quite a bit of edema in there. So we'll go ahead and talk to him and see kind of how it's affecting him and then go from there. All right, perfect. So we'll go ahead and look at his x-rays as well. So we can see on the plain x-ray, just this increased whiteness in the ball. That's just that area of avascular necrosis. So that whole area in that ball is dead. Other hip looks pretty good though, so hopefully you won't have any issues there. So, all right. Hello, hello. How are y'all? Hey, Dr. Logging, nice to see you. All right. This is Caitlin. She's my assistant helping me. What's going on? Uh-oh. How long has it been bothering you?
Let's see. I told the nurse that gave me the x-ray, or the technician, that the attack happened in April.
Okay.
But for 2 to 3 months before that, I thought I had a twist or a sprain or something. And I'm like, that'll be all right. I'll just, get past it. I drive heavy trucks,
Okay.
CDL, and I'm up and down out of the trucks, and I've done it for around 20 years or so, and sometimes it's been labor intensive.
Sure.
And stuff. But so it got to where I was limping and, kind of, hurting. I said, well, like I said, this is gonna heal.
Sure.
Just like any sprain or something. I done twisted wrong. And then all of a sudden, one night, about 11 o'clock at night, I come up out of the bed and I called my aunt and uncle. I said, either y'all come take me to the emergency room, or I'm calling the ambulance on myself, because I was going out of my mind with pain.
Right.
And so they took me to the emergency room, and they x-rayed me, and the x-rays didn't look good. And then I got set up for MRI, and Greenwood, so I went for an appointment, to look at the MRI and everything. But I was already told that I had to have a hip replacement because this is irreversible.
Right.
But I'm here for a second opinion.
Sure.
Because they was wanting to go in my hip on a drill, saying that they could get blood flow going again.
Right.
And I'm not a guinea pig, and I don't,
Instead of prolonging that, he wants to just fix the problem.
Sure,
so
yeah.
I said, what would be the success rate if I did do that procedure? Well, it might work and it might not.
Right.
I so if it,
yeah. Right, correct.
Yeah, if it, so if it, the next told me, like you say, to collapse. I said, and then how much longer, oh, it'll be 3 more months for you, I said, no. So I found out about Palmetto and you, and so I scheduled an appointment.
Sure. Okay. And when you get pain, where's all your pain? Is it more like in the groin in the front? Right in that area?
One area right in here, and sometimes it'll fire off around the back also.
Right.
But it's mostly right in here.
Gotcha. Can I take a look at it? Move that hip around? Does it hurt for me to bend it?
They're right there.
Feel it there?
Mm-hmm.
That's there. I don't want to torture you with it.
Yeah.
Have you seen your x-rays on your hip?
I haven't seen the latest.
The latest ones? These are the ones that we took today, and I looked at your MRI as well. But if you look, you can see this kind of white patch here in the bone. Okay, It's kind of subtle, but see, it's kind of normal, and then it turns this really dark white. You don't see that on the other side, but that's the area of what's called avascular necrosis. And so, for whatever reason, blood supply to that area of the bone got disrupted, and so now that area of the bone is dying. And so what happens is, over time, as that weakens, the bone will collapse and crumble in, and then it gets really, really painful. You probably already have a little bit of collapse. You can see that the 2 joint lines don't really line up. It's very subtle, but right here, they're off just a little bit, and so that means you've had some collapse already. So that's another reason why what they were proposing to do is what's called a core decompression, where you go in and drill to try to stimulate blood flow in. It doesn't really work that great. And once you have collapse, it's guaranteed not to work. And so, at this point, with the collapse that's there, the avascular necrosis, and it's pretty extensive, the only way to fix that is a hip replacement.
Yep.
But, the good thing about the hip replacement is it will take care of all of that pain. It's going to improve your mobility, allow you to get back to doing all the things you want to do.
Go back to work.
Yep. And then not have to worry about it anymore. The replacement, because you are on the younger side, so the replacement I use, though, they do claim last over 30 years. So it should get you pretty far down the road. There is the chance you might have to, depending on how long you're hanging around, you may have to have, something else done to it down the road, but there's a good chance this would be the only thing you ever have to do for it. The way that I do my hip replacements is different than most people. So I do what's called an anterior approach, meaning I come from the front part of the hip. It's a little small incision, but the benefit of the anterior approach is we don't cut the muscle, so it makes the recovery about half the time.
Wow.
Plus, you have more normal hip function because we're not damaging that muscle. So recovery, typically, you're up and walking right away afterwards, so you can put weight on it, you can move it. Because we don't cut the muscle, there's no restrictions on how you can move the hip. Most people will use a walker maybe for a week, and then a cane for a week or 2 after that. 2 or 3 weeks, you're getting around great. Usually already feeling better than you did before surgery, but still a little bit of soreness and swelling. Obviously, it takes a few months for that to kind of fade away. And by 6 weeks, you're back doing pretty much whatever you want to do.
And that can be released to go back to work at that point?
Yep. So typically, most people can get back to work regardless of their job by 6 weeks. And then you're a truck driver, you said, or
yes, we
are heavy equipment.
Heavy equipment operator.
Gotcha. So going back to that, with the pedals and things like that, you'd probably want to give it between 4 to 6 weeks. I'd say 6 weeks to be safe, but you should be good after 6 weeks.
Wow. Yes, that sounds a whole lot better than what I got from Greenwood.
Sure. Sounds good.
That sounds great.
Yeah. Do you want to go ahead and talk to the scheduler, or do you want to think about it? Go ahead and talk to the scheduler?
Yes, sir.
Okay. All right. Well, come on back here with me, and we'll go talk to her, and we can see what we can get worked out.
All right.
Sound good?
Yes, sir.
All right. Right back this way with me. right, and y'all can have a seat right there. This is Beth, and she's going to get everything scheduled for you.
So how long will it be, like an outpatient surgery?
So it's outpatient, so he's able to have it done, go home the same day. Yep. So, and then we'll get you started with therapy right after that. And you can do that therapy, you know, close to home, so in Clinton or wherever most convenient for you. But like I said, you'll be up and walking that day. So at Surgery Center, we can probably try to squeeze that in somewhere.
Sure can.
All right, perfect. So Beth will get everything worked out for you. It was great to meet you.
Great to meet you.
All right, good to meet you. And we'll see you soon, okay?
Where Chapin is?
Oh, I know, yeah.
Okay.
Just past Newberry.
That's right across the road from Chapin High School, if you're familiar with that, okay? Now, I do have to get you to sign a consent form for the surgery. First question is regarding smoking. Are you a current smoker?
I am, but I have cut way back.
You have cut way back, okay. Dr. Logan does like for you to quit smoking leading up to surgery. So we will get you to sign a form for that stating that you're going to stop smoking prior to surgery, okay? So if you are still a current smoker, you'll initial that middle line there for me. They call you again the day before surgery to let you know what time to show up.
Okay.
Okay. Now this here is just like a little checklist of what has to be done prior to surgery. You have to have medical clearance from your primary care physician. You said you didn't have a cardiologist or a pulmonologist, and you said you had dentures, so you don't have to worry about that. So this is the main one, okay? Like I said, we'll schedule that appointment and let you know when to go for that, okay? And then this is my contact information down here. If you have any questions or concerns, you just give us a call.
All right.
All right. But we got you all set up. We'll be in contact with you soon, okay?
All right, thank you.
All right, and after he's done with you guys, you'll just go back up this hallway here. That takes you straight back out the front door, okay?
All right.
All right.
You want to put that in?
Yeah.
Got it. Y'all have a good rest of your day.
You too.
Thank you.
All right, thank you. Like I said, just call me if you have any questions, okay?
All right. Around 2004, I got my CDL license, and I went to work for Austin Powder Company, which is a blasting company worldwide, and I would supply the explosives for the quarries for blasting rock to the quarries by heavy truck. But a lot of those duties was a lot of uneven terrain, a lot of intensive labor. So the truck was like 10%. The rest of it was heavy labor and things like that, and a lot of heavy lifting. I went 10 years with them, and then I went 9 years with the city of Clinton, South Carolina, working heavy trucks, heavy equipment for them. So it was pretty intense, and I believe I've just worn myself out and caused damage. And so this past April, that's when the trouble really started bad for me. April, but a few months before that, I thought I had sprained or twisted wrong on my hip, and I thought, oh, it's just like anything else, you know, I'm gonna heal up. I just got to get past it. And then, like I said, sometime in April, 11 o'clock at night, all of a sudden, I had to go to the emergency room, and extreme pain and everything with that hip. And so they did x-rays on me then, and they didn't like the looks of the x-rays. So I went for an MRI, and it showed even worse things. And the place I had went to start with, I didn't really feel comfortable with what they was wanting to do with the drilling. So I decided, okay, I'm gonna get a second opinion. So I was referred by family members to Dr. Loggins and Palmetto Bone and Joint. And so I called them up, and they accepted me for an appointment, and I came for the appointment. And now I'm getting great news and everything that they're gonna fix me up here, that it's gonna turn out good, and I can get myself back to work and finish out my working years and get back to my lifestyle, which I believe that I'm gonna try to pace myself a little more from now on and everything, and you know, and just have a quality of life that I've been missing for a few months now, you know. But that basically sums it up, I believe, you know. But it's been hard being taken out of work and put down like this, to where I was so active before, And, you know, I was a busy person, and when you get that taken away, it can get mental also. You have to deal with a lot of things.
All right, so we'll have to talk to him about that. All right, so we got a gentleman here, bilateral knee pain's been going on for several years. X-rays we take today show basically pretty severe arthritis in both of the knees, so no space between the two bones, completely bone on bone, so he's definitely got reason to be hurting. He is slightly overweight, so we'll have to talk to him about weight loss because he's just over our BMI limit for surgery. But we can talk to him about injections or see what else he's been doing. All right, let's go talk to him. Hey.
Hey.
How you doing?
Doing good. How are you?
Doing good. Good to see you.
Good to see you.
Yeah. How you been? It's been a little while.
It's been a while.
Yeah. What you been up to?
Trying to survive.
Trying to survive.
Yeah.
Is that pain just getting worse?
Yeah. Well, you know, this has always been my worst, but
Mhm.
now I think I tore something else.
Yeah.
It's just getting sometimes unbearable.
Really?
I can't really get up and down anymore.
Now, have you been getting injections or anything, or just been
No,
kind of
just-
putting up with it?
Just putting up with it. Just,
Gotcha. And so are they gotten to be about the same with regard to pain, or is that one now the worst, or is this one still the worst?
this one's always constant, but this one now it's got a sharper pain because I can tell something's happened in it.
Right.
You know, it's just getting worse.
Okay. Can I take a peek at them?
Sure. Guess it just grinds like gravel.
Yeah.
This one has just got a bad burn in it.
Alrighty. Well, let me show you your x-rays here. So these are both of the knees, okay? So this is the right one here. This is the left one. And you know, what we're typically looking at is that amount of space between the two bones. And you can see here on the inside part of the knee, and pretty much most of the way across, I mean, there's just no cartilage left. And so it is completely bone on bone, bone spurs around it. The right one's the same way though. Now, the left one is definitely the worst of the two, but they're both completely bone on bone. So, and more than likely that kind of sharp pain that you're getting, you know, the meniscus is kind of caught in between those two bones that are now grinding together. And so you've probably torn that meniscus as well. And that's where we're getting that pain from. Now, you know, ultimately, you know, if you said, okay, what's it gonna take to fix it? You know, knee replacement would be the only option to fix it long term. And that would be for both. Now, we could always, you haven't had any injections in a while, we could always consider trying the injections. You know, those likely would help. It's just a question of how long they're gonna last. You know, and two options on the injections. One would be the cortisone. Obviously, cortisone's quick acting, so within a couple days, you know, you feel relief with it. Those don't usually last the longest, but work usually pretty well. There's also the gel injections. The gel injections try to help lubricate and cushion the knee, so it's not so much of the bone rubbing on bone. If those work really well, usually you can get at least 6 months out of them, but they don't always last that long. But like I said, ultimately, knee replacement is what it's going to take. Now, weight-wise, you know, we would have to try to lose some weight in order to get to a point where we're ready to have surgery. Normally, we like a BMI of around 45. I think you're at 50 something, so you're just a little over where we need to be. You know, if it came down to it and you're struggling with you know, because part of it depends on, you know, where that weight is. Your knee is pretty reasonable, so we could still replace it. But you know, the problem with the higher the weight is, it, you know, just increases your risk of complications. So increased risk of blood clots, infection, things like that, stiffness in the knee. So that's why we'd want to try to get that down as much as we can. But if you're suffering with it, then we could still try to work something out for you.
Why is this one? I have more pains, like right in
On that
this
outside?
area. Yeah. It seems like the upper part is just bruised off. I mean,
Right.
when I touch, it's like touching, you know, like a bad bruise.
Right.
I mean, I know the bottom part, but it just seems like up here on this knee, it's always up here that hurts the worst.
Yeah, and some of that could be due to the fluid. So as those two bones rub together, you know, that inflammation causes fluid within the knee. And as that kind of balloons out, this is kind of a common area where it balloons out a lot. So that could be coming from the fluid and that just distension of the joint capsule that's there. You've got arthritis all throughout though, so in behind the kneecap. And so some of that could just be due to that arthritis that's there on that outside too. So, or a combination of both.
Arthur's everywhere.
Yeah, yeah, he's got those knees for sure. So.
Well, I found out there in my elbows and this one.
Is that right?
Yes.
Well, do you want to try the injections today and see how that does?
That'd be great.
Okay, so we can do the cortisone today. We would have to get authorization with the insurance to do the gel. So what we could do is do cortisone today and then have them get the authorization and then have you come back and then do the gel. Well, let me draw up your injection here. So we're just drawing up our injection. We've got a little bit of lidocaine, which is our numbing medicine. And then we're also going to put the depomedrol, which is our cortisone, to really try to help calm that inflammation down for you. But hopefully it'll be worth it. All right, just gonna feel here on the knee. Gonna make a little mark here, and then we're gonna put some alcohol on the skin. And then cold spray, okay? So really cold. That's gonna be a stick. Doing okay?
Yeah, great.
Good.
This left knee so
Used to pain.
Yeah.
We're done. Not too bad.
Not bad at all.
Good.
Didn't feel anything actually. Now this one might be a different story.
The other one.
This one's had so much done to it, it just, like you said, the only thing you can do now is replace something.
Right. All right, that's one. Okay. Get our other one. Make a little mark, same kind of thing. Little alcohol.
I feel that.
Do you? Get the cold spray. Maybe it won't be too bad.
Oh no, I didn't even feel that one at all.
Good. Cold, cold.
I feel that. So I just grit my teeth a little more on this one.
Right.
This one's one that's been on fire.
That's gonna be a stick. Doing okay?
Yeah, that's the spot though.
We got it. You're all done.
Whew, thank you.
Yes, sir. Now take it easy today, okay? Shots normally take about 2 days to take effect, so hopefully by Wednesday you should notice improvement in it. And then, like I said, what I'm gonna do is I'm gonna have them get the authorization for the gel, and then they'll get you an appointment to come back so we can kind of do that and see how that does.
Yeah, I want to ask you about, I've been reading on the new knee replacements. And your name was under the first one I looked at.
Right.
Not so invasive knee replacement.
Right.
Where they cut the muscle under the kneecap back.
Yeah, so yeah, the traditional way that most people do the knee replacements is they make the incision down the center of the knee, and when you do that, they cut into the tendon and muscle. But then you're trying to do therapy afterwards and bend it and move it, but it's been cut, so it hurts and it's hard to get the mobility back. So what we do is we come from the inside part of the knee, so we avoid cutting into that muscle and tendon altogether. Just retract that muscle out of the way and tendon out of the way. and that makes a huge difference on the recovery. So much quicker return of mobility, usually less pain, quicker recovery. So it's made a big difference just on the recovery for people. So that would be the way we do it whenever it gets to that point. So sound good?
Yes. I've been waiting on the best one to come out.
Yeah, that's right. That's right. Well, that's definitely the better way to do it for sure. So, all right. Well, come on up here with me, and we'll go talk to them up front about getting that gel authorization for you. I hope those help.
Thank you.
You're welcome. Right up this way for me. Okay, so we just had a quick bite to eat for lunch. We finished our morning and we had a great morning, saw lots of patients, a lot of different pathologies. Obviously we did see a good bit of knee arthritis, hip arthritis, and then other problems as well. Scheduled a few patients for surgery. We had a lot of patients that were doing well after their surgery, and so it was good to see them coming in and just happy with their results. So we got a busy afternoon ahead, so we're about to get started back, and so we'll go ahead and get started. Right knee pain has pretty advanced arthritis, mild varus deformity to the knee, so completely bone on bone. Left knee doesn't look great either, so maybe problems with both. So we'll talk to them and see what's going on. Hello, hello.
Hey, how you doing?
I'm doing good. How are y'all?
Good.
Good to see you. Dr. Logging, nice to see you. This is Caitlin. She's my assistant helping me. What's going on?
Wearing out.
Wearing out?
Days,
Oh
yeah.
no, that's no good. How long they been bothering you?
Well,
Long time.
2 years, yeah. I had this one scoped
Okay.
probably about 15 years ago. I had a torn meniscus
Right.
and cleaned the arthritis up in it.
Sure.
You know, I'm on the arthritis medicine. I can't remember the name of it. But sometimes it helps, sometimes it don't.
Right.
You know, Tylenol. I ain't too bad today. I took Tylenol before I left home.
Okay.
But
the right one's the main one that bothers
Right
you.
one.
Do you get problems on the left or some? Yeah.
like when I squat, this thing feels like it's grinding in there.
Sure,
you
sure.
know. And,
He walks by me, I can hear
You can hear it. Yeah. Have you had injections in the knees?
I've had cortisone,
Right.
then I had a booster,
Uh-huh.
then I had cortisone,
Okay.
and then I had gel.
Okay.
Cortisone the first time and the booster
Yep.
did good.
Right.
After that, the second cortisone was about 3 days, and I couldn't even tell the difference on the gel.
On the gel. Oh man. I'm sorry.
Yeah.
Can I take a peek at them?
Yes, sir. Do what you want.
Have you noticed that knee's kind of bowing a little bit?
Yeah.
Yeah. A lot of that, unfortunately, is due to that arthritis in those knees. Now, have you seen your x-rays on the knees? All right, so these are both of the knees. So this is your right one, this is your left one. And you know, what we're typically looking at is the amount of space between the two bones.
Right.
And you can see there on the inside part of that knee especially.
I get a lot of pain here.
Yeah.
And I get like just an ache right here, you know, like,
Right.
you know, on this side. It feels like it's more of maybe the tendon or something right there.
Yeah, pain in the back of the knee is pretty common.
Okay.
And just a lot of it's due to the muscles and tendons that are there, but also a lot of times when you get you know, that severe arthritis, people will also get what's called a Baker's cyst. And so it's a cyst that forms in the back of the knee, which is just due to the inflammation. So the fluid that builds up in the knee, the weakest part of that capsule is in the back, and so that fluid starts ballooning out the back, and that's what gives you that pain in the back of the knee. So that's pretty common. You know, if you said, you know, I want to fix it, you know, that usually does get better after surgery. It takes a little while, so that you may still have a little bit of that pain afterwards, but that usually will all go away. But yeah, that's pretty common with what you got going on. Left knee, you know, doesn't look much better though. I mean, it's pretty much the same, completely bone on that inside part too. So, I mean, you've got reasons for both of them to be hurting for sure. So, you know, obviously if you said, okay, well, what's it gonna take to fix it? would take a knee replacement in order to fix it, but hopefully the knee replacement would do pretty well for you. It would help straighten the alignment, so it'd take that bowing away. But the big thing is it stop the bones from rubbing together and then get that pain to settle down.
Would it be a complete knee replacement?
So it'd be a complete knee replacement.
So the Jiffy?
Yeah, so the Jiffy technique is...
that's what draws me to you.
Yeah, sure. So the difference in the traditional technique and then the Jiffy technique, and so the traditional technique is you make that incision down the center of the knee, and when you do that, you have to cut into the tendon and muscle. But then you're trying to do therapy after surgery and bend it and move it, but it's been cut, so it hurts and it's hard to get the mobility back. So that's what traditionally makes it take so long to get over. So the Jiffy technique is we come from the inside part of the knee, so we avoid cutting into that muscle and tendon altogether. So that helps make the recovery quicker return of mobility and muscle function, and then usually less pain. Still a knee replacement, the implants are the same regardless of which technique you used. It's just by not cutting that muscle and tendon, it just helps make the recovery a lot better. So typically recovery, you're up and walking right away afterwards. Most people will use a walker for about a week and then a cane for a week or two after that. So 2 or 3 weeks, you're getting around good. You're in physical therapy during that time. But there's still a fair amount of soreness and swelling. That takes about 3 months for that to kind of fade away. But by 6 weeks, most people are starting to get back to doing most activities they want to do. So recovery is a lot quicker when you, like I said, when you don't cut that tendon. Pretty normal after the replacement, still to notice a little popping and stuff. That's due to the swelling and some scar tissue that may be there. That usually works its way out with time. And like we mentioned, it's normal to have some pain in the back of the knee as well, and initially afterwards. And that all usually just kind of works its way out with time.
After surgery, how soon do you put weight on it?
Yeah, so you can put weight on it right away. So the day of surgery, you can put full weight. You can move it freely right away afterwards. Yep.
Does it make it feel any different? I mean,
so
if my knee was healthy,
Right. So everybody's a little bit different with that. I would say, most people feel like it is slightly different, but there's just not that pain that's there. I have some patients who are like, I can't tell, it's not mine. And so, but I would say most people, you can tell it's a little bit different. It's not your normal, but it's functional. You can do all the things you want to do, and the biggest thing is you just don't have that pain. That's right. That's right. Typically don't recommend doing both at the same time, obviously. Since this one's the one that really bothers you the most, obviously if you wanted to do that, we'd start with that one.
Well, I gotta have something.
Yeah.
Maybe a wooden stick. I don't know.
Yeah, because if you don't do anything about it, it will only continue to get worse. The bowing will continue to get worse. And so
it's really progressed probably the last year.
Yeah, so it's probably best to consider going ahead and getting that done. Okay. Do you want to think about it, or do you want to go ahead and talk to the scheduler to see about trying to get it scheduled? Get it done? Okay. All right, well, come on back here with me and we'll go talk to our scheduler and see what we can work out.
Good morning, how are y'all?
Good, how are you?
Good.
This is Beth. She's my surgery scheduler. She's going to get everything worked out for you. All right, very good.
All right.
And it was good to meet you.
Yes, sir.
We'll get you fixed up, okay? All right,
Thank
good
you.
to meet you. You're welcome. Y'all have a great day, okay? All right.
My name's Kayla, and I am the appointment scheduler for Palmetto Bone and Joint. Also kind of manage the front, make sure everything's going good. I've been here about 12 years. I started off at the Clinton office, and I've been in Newberry for about 9 years. So I make all the appointments for all the doctors, schedule meetings, schedule lunches, anything with the doctor's schedule I take care of. I'm married. I have 2 kids, a boy and a girl. I love working at Palmetto Bone and Joint because the doctors are so good to us, especially Dr. Logan. They treat us really good and treat us like family, really. That's what I love working about here. And the girls, we all get along so good. We're all like family. And I love it here. I guess that's why I've been here 12 years.
Hello, hello. How are y'all? How's everything doing?
Doing well. How are you?
Doing good.
Good.
How's things coming along?
Great.
Great. No problems? Feeling better? Yeah. Still doing therapy? Nope, they've already turned you loose, or you turned them loose?
I turned
You turned them
Well,
loose.
there was some circumstances to that.
Okay.
We had the surgery.
Right.
Then we got sick.
Oh no.
2 days, 3 days after.
Oh no. Oh no. That's no good.
Bad.
Yeah.
And so we were out of therapy for 2 weeks.
Right.
And then back in it, and he went on vacation, and then last time I was here, I said, I'm doing great.
Yeah.
And I done been through this.
You've been through, that's right.
I've been through this three times.
Right.
I
Exactly.
got it. So I do my therapy at home.
Perfect.
The exercise they do it, and like I told him, I'm 70. I'm not climbing the mountain ever, or doing anything crazy, kayaking down the river.
Nice. That's great.
But I hadn't done that yet. But
That's on the goal.
That's on the roll. That's
Yeah.
the next plan. As soon as these rivers stay down, and they come cleaned up.
Yep. I'm proud of you. I think you're coming along good. So I think that's totally fine. Yeah, like you said, you've been through it before. You know the exercises. Just continue to work it on your own. The more active you are, the better it's going to keep getting
And
strong.
we're walking.
Perfect.
Yeah.
Yeah.
So I'm start walking in my wedges next week.
Uh-oh.
Start practicing on that.
I hear you. I hear you. Can I move that hip around? Feels good. Well, I'm proud of you. I think you look great. X-rays look great, so everything's looking good. Any questions about anything?
Fantastic.
Yeah.
Like I said, this is my third rodeo.
Yep.
We drove from Brevard, North Carolina
Yep.
to here to have it done.
Right.
I haven't gone anywhere else.
Well, thank
I'm
you.
very happy.
Well, I'm glad. Yeah, like I said, I'm proud of you. I think you've done really well. Hopefully things just keep getting stronger and better. And then I'll turn you loose today, but obviously if there's any problems, you know where I am. Call me, come on back. Sound good?
That's great.
All right. Well, if you give this to them up front, they'll get you checked out. And like I said, if you need me for anything, you give me a call, okay? All right.
Thank you.
You're so welcome. Proud of you. You're so welcome. And just hand that to them on the way out, okay? Y'all have a wonderful day.
The one that they just operated on fell and broke it about 16, 17 years ago. And so I had hardware put in. And after 16, 17 years, I kind of wore it out. So we had a hip replacement. And the left side I had replaced about 1.5 years, 2 years ago. So 2 hips, 3 surgeries, best doctor, traveled all the way from Brevard, North Carolina, just for him. Yeah, and I have that osteoporosis stuff too going on, bad bones. And I just wore it out. When I broke it and wore it out and got rushed to Newberry Hospital, and they said, I had to be in traction for a couple days, and he did the surgery, and I did great with that. So, and used it for 16, 17 years and back again.
All right, so we got a new patient here, 69-year-old, right shoulder pain, x-rays, show a little bit of arthritis in the shoulder, a little spurring underneath the acromion. Let's see, we'll do type 2 on that. All right, and then we'll go talk to them and see how we're doing. Hello, hello. How are you?
Good. How are you?
Good, Dr. Logging. Nice to see you.
Nice to meet you.
Yeah.
Really nice to meet you.
Oh, well, good. Well, good. This is Caitlin. She's my assistant helping me. Well, what's going on?
Well, I guess I'm here from more peace of mind.
Okay, sure.
It's my husband brought to my attention that he thought that my shoulder, one of my shoulders was dropping like about 2 inches down.
Okay.
And so anyway, I really don't know which side. I have MS.
Okay.
And so anyway, and it's on my left side.
Oh, is it? Okay.
Yes, okay, and so anyways, and everything, I've had knee replacement on my left side, and my left foot is what, so I don't know, between my foot and my shoulder, I'm just here to find out.
Sure.
Get some information.
Okay. So was it more the left shoulder that he noticed it on, or the right? He says it's the right one. Or is there pain with it? So no pain at all. He kind of notices that one does kind of drop some. Can I move it around? So full mobility, none of that hurt you. Can you hold your arm out here in front of me like that? Don't let me push it down, hold it tight. Does that hurt? Nope, okay, good, you can relax it.
Okay.
All right, I'm just gonna slide these sleeves up here, and you just let that arm relax by your side, similar to this.
Okay.
Yeah, it's very subtle. I kind of see what he's talking about. This one does seem to be drooping some. Now, it's possible some of that's related to the MS. I mean, that's a possibility. X-rays on the shoulder, you got a little bit of arthritis that's in there, a little spur that's there, but nothing major on the shoulder. The ball and the socket are in pretty normal orientation to the shoulder, so it's probably been more muscular than anything else, which is like why I said it's just related to the MS. If it's not causing you a lot of pain, then I'd probably watch it. We could get an MRI just to make sure there's no tear of the rotator cuff or something like that, because we can't see that on a plain X-ray. So that would be one option. The other option is that we could always try therapy to see if they could strengthen those muscles and whether that would help kind of balance the shoulders back out. And so that may be a reasonable option to consider doing, is just do a little therapy on it and just see if that makes a difference. And then if not, then we can always get the MRI. Yeah, do you want to try that and just see if that helps? Okay. So what we'll do is I'll have them print out the prescription for the therapy for you when you check out up front. And then they'll also get you an appointment to come back afterwards, just so we can see if that's made a difference and if it's any better. Sound good? All right. We'll come on up this way and we'll see about getting that for you, okay?
Hi, I'm Lisa Bobo. I do the financials here at Palmetto Bone and Joint. Payroll, I pay the bills, collect the bills. I've been here 25 years. It's a great place to work.
All right, so this patient's got arthritis in the hips, and we had done a hip injection. So we're just following up to see how that injection is done. So we're gonna check in. Hello, hello. How we doing?
Good morning.
Good morning, I'm doing good. All right, well, how's everything doing? Yeah, how did the injection in the hip do? Didn't help at all? No. No.
I have a lot of arthritis in my hip.
You do have a good bit of arthritis in your hip. Some of it could be coming from the lower back too, though. That injection didn't do a lot. You can get pain from the back that refers into the hip.
Pain in my back that feels more muscular.
Does it?
Yeah, I've been by a week. I've been doing some exercises, but they seem to help. In fact, it makes it worse.
Right.
Actually.
Yeah, I can imagine that.
So when you do my hip replacement, are you taking out that arthritis?
Yeah, so we do clean the arthritis out, which is the damage to that cartilage. So we remove the ball, clean out the socket, put a new socket in, and then there's a stem that goes in the thigh bone with the new ball attached to it. So.
Oh, am I going to be down?
Yeah, so the way that I do my hip replacements is different than most people. So I do what's called an anterior approach, meaning I come from the front part of the hip. Little small incision, but the benefit of that is we don't cut the muscle, so it does help make the recovery a lot quicker. So you're typically up and walking right away afterwards. You can put weight on it, move it. Most people will use a walker for about a week or so, and then a cane for a week or two after that. And then 2 or 3 weeks, you're usually getting around pretty good, but there's still some soreness and swelling. Obviously, it takes a few months for that to kind of fade away. But by 6 weeks, most people are starting to get back to doing most activities they want to do.
So I'll have to get out of my yard for X number of weeks.
Yeah, I'd probably say 4 to 6 weeks. Yep.
Question.
You might could do it sooner, but yes, sir.
Do you think that's the reason she cannot walk without using a walker at this point?
It's hard to say. I mean, that may be part of it. Part of it could be the back as well.
Well, I had that spinal cord injury.
Right. So that could play a factor in it, for sure.
And I'm about 11 months in with that.
Right.
So I want to walk for you and see if you think my hip is.
Sure. Sure. Do you want to walk down the hall or just here in the room?
I'm just gonna walk right here.
Okay.
favoring this.
You are favoring it.
I think I was already doing that before I had my phone.
Yeah.
So you think if you do my hip, it's gonna help me get my gait a little better?
I mean, I would hope so. I mean, if that's where a lot of that pain, the limitations coming from is that pain in that hip, yeah, if we correct that, then hopefully it would. Like I said, if some of it's related to the back.
I know it's still be something related to the back.
Yeah.
There's scoliosis in there.
Right, yep. So it may not take it all away, but I mean, my hope would be, I think it would help.
And I have a lot of burning in there and down this thigh.
Mm-hmm.
Is that related to the hip?
It can be. So the obturator nerve comes over the top of the hip, and so if there's a lot of inflammation around the hip, it irritates that nerve, and you'll get pain in the thigh down to the knee like that.
I think I had some of that already before I fell.
Did you?
Because when I have an issue with this leg more.
Right.
Like when I sit in my chair, if I recline, I have to help this leg up. But I was doing that before I fell.
Right.
Maybe not quite as bad, but.
Sure.
So all that's related to the skip.
Potentially, yeah.
So you think I got to get the skip done?
Yeah, I mean, that'd be the only other thing, especially if the injection didn't seem to do a lot.
Yeah. But you would be optimistic that I would get.
I think it's a good chance that it should make a difference for you. Like I said, I think some of it's the back, so it may not take away all of it, but I think there's a good chance it's going to help a lot of it.
Well, let's go for it.
Yeah. Do you want to go ahead and talk to the scheduler to see about?
I've already got it scheduled.
Oh, so it's already scheduled.
Yes, it's scheduled at the end of September.
Okay, perfect. So that's coming up soon. So
she would say here overnight one night, or?
yeah, because we're doing it here at the hospital.
I would definitely stay up.
Yep. So that's the plan. Alrighty. Well, if you give this to them up front, they will get you checked out, and then I guess I will see you in September.
Absolutely.
Sound good?
I'll be looking forward.
All right. Good to see y'all.
Yes, sir. Good to see you.
All right, and just hand that to them on the way out, okay? You take care.
And you as well.
Any questions in the meantime, let me know, okay? Hey,
Hello.
how are you? Good.
I'm better.
You're better?
I had some blood clots.
That's-
why I had to get my
That's what I hear.
so,
How'd that happen? It just out of the blue?
I don't know. I just woke up one day and my legs was on fire.
Oh,
But now I'm off my medication.
okay.
So,
Off the blood thinner? So they've already got you off of that?
yeah,
Okay.
so, I don't know what you suggest for me to do. I'm still having problems.
Right. Yeah, I know we had planned, because that first injection we did seemed to help really well. So I know we had planned to do another one, and then obviously all that happened. We could definitely get you scheduled to try another injection and just see if we can calm it back down,
Okay.
since the other one did so well. You want to do that?
Yeah, I'm just scared about on that blood.
On that blood thinner? Yes, ma'am. But yeah, now that you're off of that, that'd be totally fine to do. So, all right. So what I'm going to do is I'm going to have them get you scheduled for the injection, and then they'll get you an appointment to come back afterwards so we can see how that does. Okay. All right. Any other questions?
I think that'll be it.
That'll be it.
I've been gaining weight, so I don't think it's time for no surgery.
Oh.
But it's hard to lose weight.
I know, especially especially after the blood clot, because you can't be as active for sure. So maybe we get this shot, you can be a little more active, and then that'll help some. Yeah, because we would need to try to lose as much as we can before surgery, but we'll keep a check on it though, okay? All right, well, come on up this way with me and we'll see about getting that scheduled for you. Okay, so we finished up a great day in the office today. Saw quite a few patients, some around 60, 65 patients today. A lot of patients following up after their surgery, doing really well. So it's good to see patients doing well after their surgery. Pain's gone, be able to get back to doing the activities they want to do. Saw a lot of patients today as well that are having a good bit of problems which require surgery. So we did get those patients scheduled for surgery, and so we'll look forward to hopefully helping them be able to get rid of that pain and get back to an active lifestyle. So now that we're done for the day, we're going to plan on heading home. Spend some time with family, and then get ready for a day of surgery tomorrow.